Laser Dentistry, Light in the Mouth. Chapter 1, The Dentist's Brother's Tooth. I want you to begin by holding something in your mind. A man, standing in a laboratory in 1965, pointing something that looks like a futuristic ray gun at a tooth. The tooth belongs to his own brother, who is a dentist. The man pulls the trigger, and a pulse of pure red light hits the enamel. The man's name is Leon Goldman. He is not a dentist, he is a dermatologist, and he has just done something that is either the birth of a new field of dentistry or a slightly reckless experiment on his brother's mouth. Possibly both. I find the absurdity of that genuinely charming. The first laser dentistry patient was the researcher's own sibling. It has the right flavor, curiosity outrunning caution, someone who just had to know. What happened to the tooth? Microscopic cracking across the enamel. No clean cut. No pain. Just light and then tiny fractures in the hardest tissue the human body produces. The ruby laser Goldman used could mark enamel, but it could not cut it cleanly. It deposited raw heat, and raw heat kills pulps. That fundamental problem, light poured into tooth structure as heat, damaging everything around the target, would stall the clinical translation of laser dentistry for nearly 30 years. From the first laser hitting a tooth in the mid-1960s to the first laser safe enough to actually cut human teeth in 1997. The idea came first, the working device came second, and the safe, clinically validated version came third, decades third. The laser itself was not invented for dentistry. It was pure physics, theorized by Einstein in 1917, built for the first time by Theodore Maiman in 1960. Dentistry was an afterthought, a beautiful, contested, overhyped, genuinely revolutionary afterthought. This episode is recorded for practitioners and students. You already know the mouth, the drill, the scalpel, the burr, the file. What I want to give you is the laser, not the marketing version, not the conference booth version, but the real thing. The physics, the procedures, the evidence, the honest limitations, the genuine advantages. And I promise you, by the time we reach the end, you will know exactly what light can and cannot do inside the mouth. Welcome to Laser Dentistry. Chapter 2, The Physics You Actually Need. Everything in this episode rests on one idea. If you understand it, you can reason about any laser in any procedure. If you do not, you are at the mercy of whatever the brochure tells you. The idea, wavelength choice, is built-in tissue selectivity. Before you touch a setting, the wavelength you pick has already determined what it can and cannot cut through physics, not brand preference. When a laser beam hits tissue, only one thing produces the clinical effect: absorption. And absorption depends on chromophores, molecules that absorb light. In the oral cavity, four matter: water, hemoglobin, melanin, and hydroxyapatite, the mineral of enamel, dentin, and bone. Every dental laser wavelength has a different absorption profile across these four, and that profile dictates everything. A diode at 810 or 980 nanometers is strongly absorbed by hemoglobin and melanin, but essentially not at all by water or hydroxyapatite. It is suited to soft tissue, vascularized, pigmented, the kind that bleeds and incapable of cutting enamel. This is not a marketing limitation. It is literally what the photon physics allows. The photons pass through hydroxyapatite like light through a window. No absorption, no ablation. Conversely, an erbium laser at 2,940 nanometers sits almost exactly at the peak of water's absorption in the infrared spectrum. Because enamel, dentin, and bone all contain water, the erbium beam dumps its energy into that water almost instantaneously. And what happens next is the most vivid piece of physics in this entire field. The water heats so fast it cannot boil off gradually. It is trapped inside a rigid mineral matrix. Pressure builds. In a microsecond, the water flash vaporizes in place, and the pressure spike mechanically fractures and ejects the surrounding hydroxyapatite. The tooth is blown apart by steam pressure, not melted, not charred, blown apart, from the inside, in millions of tiny controlled explosions. You can hear it, a distinctive popping, clicking sound, nothing like the whine of a burr. The erbium laser does not burn the tooth away. It uses the tooth's own water content as a built-in demolition charge. That is a genuinely elegant piece of physics, and it is the single most important mechanism in this entire field. The crucial corollary: the water spray is mandatory, not just cooling. Without it, the laser runs out of its primary chromophore, ablation collapses, and energy shifts from mechanical microexplosion to conventional thermal heating. The cold chisel becomes a hot knife. The exact failure mode that stalled Goldman's Ruby experiments comes roaring back. And pulse timing, each pulse shorter than the tissue's thermal relaxation time, with gaps long enough for heat to diffuse, is the engineering insight that took dentistry from charred 1960s enamel to today's clean cavity preparations. And I want you to understand the temperature landscape, because it governs everything you do at the chair. Below roughly 42 degrees, nothing happens. Between 60 and 70, protein denaturation occurs. This is the coagulation zone where hemostasis happens, where blood vessels seal. At 100 degrees, water boils, tissue vaporizes. Above 150, carbonization begins. Charring, the tissue burns. Every laser interaction in the mouth lives somewhere on this spectrum, and the skill of the operator is keeping the target tissue in the right band. Coagulation for hemostasis, vaporization for cutting, and never, ever carbonization. The single most important habit I want you to develop is to ask, every time you hear a claim about what a laser can do, which chromophore, which wavelength, what does the absorption physics actually permit? If you ask that question, you will never be fooled by the marketing. Chapter 3: Your 3 lasers. There's a single organizing principle that explains the entire equipment landscape. Wavelength is dictated by chromophore physics. Soft tissue-only wavelengths, diode, ND, YAG, classic carbon dioxide, share poor hydroxyapatite absorption and cannot cut teeth. All tissue wavelengths, YAG, CR, YSGG, the 9.3 micron carbon dioxide, share strong water and hydroxyapatite absorption and can. That is the cleanest binary in the field. The diode, 810, 940, 980 nanometers, plus newer blue diodes at 445. Chromophores, hemoglobin and melanin. Soft tissue only. Delivery, flexible fiber, contact mode. The workhorse, cheapest, most portable, the entry point for most general practices. Its headline advantage: because hemoglobin is the chromophore, it coagulates as it cuts, producing the bloodless field that lets you contour gingiva with a clear view. One nuance I must flag: in contact mode, the fiber tip is often deliberately carbonized, initiated, and that char-coated tip absorbs the laser light and transfers heat thermally. The actual cutting is partly a hot tip thermal effect, not pure photonic absorption. This matters for understanding lateral thermal spread and why diodes have a deeper coagulation zone than erbium. The ND YAG, 1064 nanometers. Same chromophore family as diode, but free-running pulsed through a flexible quartz fiber. The laser behind the LANAP protocol. It penetrates deeper into tissue than diode, which is both an advantage, deeper coagulation, deeper pocket disinfection, and a risk, because greater thermal penetration is possible if parameters are too aggressive. The Perio lays used in LANAP fires for only a tiny fraction of total treatment time, with pulse spacing that allows thermal relaxation between pulses. The YAG, 2940 nanometers. The strongest water absorption of any dental wavelength, the all-tissue workhorse. Delivered via articulated arm or hollow waveguide, the wavelength does not transmit efficiently through standard quartz fiber. The CR, YSGG at 2780 nanometers is the same erbium family, but with water absorption roughly 1/3 that of YAG. Biolase's waterlase compensates by energizing a water and air spray as part of the cutting mechanism. A real trade-off. Bench studies show CR, YSGG produces significantly deeper thermal penetration into tooth structure than YAG. They are both erbium. They are not the same. The classic carbon dioxide laser, 10,600 nanometers, extremely strong water absorption, very shallow penetration, superb soft tissue incision with excellent hemostasis. In use since the 1970s. But it cannot cut teeth, 10.6 microns is poorly matched to hydroxyapatite. The 9.3 micron carbon dioxide system, the Solia by Convergent Dental, reached clinical use in 2013. They did not pick a new laser. They tuned the gas inside the old one, shifting the wavelength closer to a hydroxyapatite absorption feature, one of the most elegant engineering pivots in this field. 6 lasers, 2 categories, 1 principle. Wavelength determines chromophore. Chromophore determines tissue. No brochure can change the photon physics. And a note on delivery: near-infrared wavelengths transmit through flexible quartz fiber, which is why those lasers feel like a flexible hand instrument. Mid-infrared wavelengths require articulated arm or hollow waveguide, which is bulkier. The delivery system shapes the ergonomics, the learning curve, and ultimately which laser gets used most in your practice. It is the kind of thing that does not show up in a spec sheet, but shows up every day in the operatory. Chapter 4: The Bloodless Field. Let me take you into the clinic, starting where the evidence is strongest and the controversy least: soft tissue surgery. The thread running through nearly all of it is the bloodless field, photothermal coagulation of blood vessels in the incision path, because hemoglobin is the chromophore for diode, Nd, YAG, and carbon dioxide. You are contouring gingiva around an anterior crown, and instead of packing cord and waiting and managing seepage, you make the cut and the field is dry. You see the architecture immediately. You can scan, or impression, or place a temporary, all in the same visit. That is not a marginal improvement. It changes the workflow of the appointment. The master trade-off: diode and Nd, YAG heat tissue to roughly 500 micrometers depth, deep coagulation, excellent hemostasis, but more collateral heat. Erbium penetrates only a few micrometers, and carbon dioxide 5 to 40, shallower, gentler on margins, but weaker coagulation. And here is a counterintuitive beat I want you to hold on to. Measured coagulum thickness after gingival incision is 18 to 38 micrometers for YAG versus 138 for diode. The periodontal literature reframes erbium's thin coagulum as a healing advantage: less interference with the wound cascade, less necrotic debris for the body to clear. The best laser is not always the one with the strongest hemostasis. It depends on what you are optimizing for. Gingivectomy, gingivoplasty, operculectomy, troughing for impressions, these are the bread-and-butter soft tissue applications. The advantages over scalpel and electrosurgery are real and well-evidenced: dry visible field, comparable or faster healing, bactericidal effect on the wound bed, something scalpel and electrosurgery simply do not have, often topical anesthesia only, fewer sutures. The honest limitations: lateral thermal spread near bone is a real risk. Electrosurgery is outright contraindicated near periosteum for necrosis risk. Lasers are gentler but not risk-free. On thick fibrotic tissue, a fiber laser can be slower than a scalpel in skilled hands. Let me give you a clinical vignette that captures the troughing advantage. The single biggest problem in cord retraction is bleeding and seepage contaminating the scan or impression. You pack cord, the tissue bleeds, you wait, it seeps again. With a diode laser, you ablate a precise sulcular trough with simultaneous hemostatic sealing. No cord, no discomfort, no oversized cord recession risk. You can scan immediately. For a practitioner doing digital workflows, that is the kind of advantage that pays for the laser one quiet procedure at a time. Aesthetic crown lengthening and the gummy smile, this is where the wavelength rule becomes clinically decisive. If the objective is soft tissue, only a diode is sufficient. The moment bone needs to move, a diode is insufficient. You need YAG, CR, YSGG, carbon dioxide at 9.3 microns, or conventional osseous surgery. A diode cannot touch bone. It is not a training gap. It is physics. And most true gummy smiles involve excess maxillary growth or altered passive eruption, not pure gingival excess. The idea that a diode alone is a full gummy smile fix is a marketing oversimplification. The advantage of the right laser is single-visit recontouring with simultaneous hemostasis. See final architecture immediately, often same-day photos or temporaries, versus the traditional 4 to 6 week scalpel cycle. Gingival depigmentation deserves attention because it is directly relevant to the Indian market, where physiologic gingival melanin hyperpigmentation is a common aesthetic request. The mechanism contrast is a perfect illustration. Diode cuts by melanin absorption, the pigmented epithelium is selectively vaporized. YAG ablates by water content, not pigment, so it is less selective. A split-mouth randomized trial found YAG had higher intraoperative bleeding and higher pain. The Chromophore matched Diode won on comfort and field control. And the recurrent story is genuinely unsettled. Repigmentation is melanocyte-driven and substantially genetic. No wavelength cures melanocyte activity. Depigmentation is cosmetic ablation of existing pigment, not a permanent fix. The honest practitioner sets patient expectations clearly. Frenectomy, infant tongue tie release, is one of the highest volume laser procedures today, and it is contested not because the laser does not work, but because the procedure rate has skyrocketed and drawn scrutiny about overdiagnosis. A double-blind randomized trial comparing Diode to scalpel in infant ankylosing found both groups showed significant functional improvement, with no significant difference in most outcomes. The laser is not proven categorically superior in functional outcome to a well-performed scalpel frenotomy. Its selling points are comfort, bleeding control, and workflow. The laser made the procedure easy. The ease may have outpaced the diagnostic rigor. The honest practitioner's restraint is the primary safeguard. The fact that you can do a procedure easily with a laser does not mean every case warrants it. The instrument is not the diagnosis. Now the single most clinically important caveat in the entire soft tissue literature: biopsy and the margin. When you laser excise a lesion, the thermal artifact at the cut edge can alter the histological margin. Studies have measured thermal damage zones averaging 200 micrometers in epithelium and over 300 in connective tissue for a diode. The critical guidance: at least 2 millimeters of grossly normal tissue should be included around any laser-excised lesion when histologic margin assessment matters. If there is any suspicion of dysplasia or malignancy, prefer cold steel scalpel excision so pathology gets a clean, unambiguous margin. The laser is wonderful for benign excisions, fibroma, mucosal, papilloma. The moment dysplasia is even a minor consideration, the thermal artifact becomes a diagnostic liability. This is where the laser's advantage ends and the scalpel's begins. Know that boundary, because getting it wrong means a pathologist reading a compromised margin on a lesion that could be malignant. For implant second-stage uncovering, diode or carbon dioxide for the simple soft tissue incision to expose a submerged implant, the diode causes a necrosis zone of only 3 to 5 cells deep versus 300 to 500 for electrosurgery. Let me say that again: 3 to 5 cells versus 300 to 500. The laser's advantage is incremental, faster hemostasis, better same-visit impression accuracy, not a must-have. Implant success is governed by osseointegration and prosthetic factors, not the uncovering instrument. But the thermal safety profile near titanium is superior to electrosurgery, and for a practitioner who already owns a diode, this is a low-controversy, high-value use case. Chapter 5: The Tooth That Was Not Drilled. Hard tissue laser dentistry, cavity preparation and caries removal with erbium, is the application that made the field clinically real. The mechanism is the microexplosion, water inside the tooth, flash vaporized, ejecting hydroxyapatite as a fine spray. The popping sound, the water mist, no vibration, no drill whine. I want you to imagine the sensory experience for the patient. They have been told their whole life that the drill is coming, the sound, the vibration, the smell of burning dentin. And instead, they hear a rhythmic clicking, like tiny tap-tap-taps on the tooth, and they feel a cool mist. For anxious and pediatric patients, that sensory difference is itself an anxiety reduction lever independent of any analgesic claim. I have come to think that the sound and feel of the Erbium laser is one of its most underrated clinical assets, because the fear of the drill is not just about pain, it is about the entire sensory assault. Remove the assault, and you remove a barrier that keeps people out of the chair. A pivotal early trial compared YAG to the drill. Patients consistently treated without anesthesia with the laser. 42 of 42 drill procedures and 81 of 82 laser procedures rated successful. A genuinely strong result. But the honest nuance, when pain scores, not anesthesia usage, but reported pain, were compared directly in some trials, no significant difference was found. The laser's real advantage is in avoiding the anesthetic injection, often the most feared part of a visit, not in making the cutting itself painless versus a numbed drill. The blanket claim that laser fillings are always painless is a myth. Less need for anesthesia is not the same thing as the procedure is painless, and the distinction matters for how you set patient expectations. And the speed limitation, the single most consistently reported limitation in the entire hard tissue literature. A randomized controlled trial reported mean excavation time of 13.2 minutes for the laser versus 4.3 minutes for the burr. Roughly 3 times longer. This is why the Erbium has not displaced the handpiece as the default instrument. It works. It is safe. It reduces anesthesia. But it is 3 times slower for bulk removal, and in a world where chair time is economics, that matters. 3 times slower, and it cannot touch an old amalgam. That is why the burr is still in every tray. There is a selective caries ablation claim that is real but operator-dependent. Carious dentin, higher in water and structurally weaker, ablates at a lower threshold than sound dentin, theoretically conserving more tooth structure. The physics allows it. The execution demands skill, because the differential between carious and sound dentin ablation thresholds is real but not enormous. A published protocol for Class V preparations, 8 Hz, roughly 250 millijoules per pulse, reported 80% of cases performed without pain. For primary teeth, the evidence is reassuring. Multiple split-mouth trials support Erbium caries removal as safe and effective in pediatric patients, with restoration survival and pulp vitality not adversely affected at 12-month follow-up. The primary tooth protocols, 300 millijoules at 20 Hz for enamel, 200 for dentin, are well documented. The critical safety counterpoint, Erbium lasers are not thermally risk-free to the pulp. The Zach and Cohen threshold, 5.5 degrees risks irreversible pulpitis, applies. Excessive energy, inadequate water, prolonged dwell, thermal injury. The laser has no inherent pulp safety property. Safety is entirely a function of correct parameters and water cooling, exactly as with a high-speed handpiece. The consolidated hard tissue limitations, the honest reasons the burr stays in every tray, 3 times slower. Cannot cut metal, ceramic, or old amalgam, a physics-based limitation, because Erbium is absorbed by water and hydroxyapatite, not by metals or dense ceramics. Cannot practically do full crown preps, lasers are suited to discrete cavity preps, not full coverage crown reduction. Significant capital cost. No universal parameter standard, clinicians must train on their specific device and cannot transplant settings from a journal article using a different system. The honest future is a hybrid workflow, laser for caries and selective prep, burr for bulk reduction, shaping, finishing, and anything involving metal. The laser is an additional tool, not a replacement. I want you to feel that framing, because the marketing will tell you it is a revolution. It is not. It is an addition, a genuinely useful, sometimes beautiful addition, but an addition nonetheless. On etching, the evidence is mixed, not a clean laser win. For fluorotic enamel, a combined protocol of YAG followed by acid etching works well, laser plus acid, not laser alone. For standard enamel and dentin, some studies found laser etching gave lower bond strength than traditional acid etch. The literature does not converge on laser etching as a universal replacement. On dentin hypersensitivity, YAG at subablative settings physically seals tubule orifices by localized melting and risolidification. SEM studies show excellent occlusion. The lowest energy, 0.5 watts, 50 millijoules, outperformed higher energies. Less is often more when the goal is sealing, not cutting. but long-term clinical durability versus chemical agents is not conclusively settled. Communicate as an effective option, not a permanent cure. For bone surgery and apicoctomy, YAG and CR, YSGG are in clinical use, CR. YSGG specifically for apicoctomy since the early 2000s, covering the full sequence of flap, osteotomy, root resection, and retrograde prep within one device. The Erickson and Albrechtsen threshold 47 degrees sustained for 1 minute is the safety cliff for bone. A case series of 65 laser apicoctomies reported success in 56, failure in 9, roughly 86% success. But it was a single-center retrospective series, not a controlled trial. The pattern, again, strong mechanism, encouraging case series, waiting for definitive comparative outcomes. Chapter 6, LANAP and the Regeneration Controversy. We come now to the single most contested claim in all of laser dentistry, and I want to give it the full treatment because it is a perfect case study in the gap between marketing volume and independent evidence. Real patients are sitting in real chairs right now, being told that a laser can regrow the bone and ligament they have lost to periodontal disease. The question of whether that promise is supported by evidence is not academic. It is clinical. It is ethical. LANAP, laser-assisted new attachment procedure, is a patented protocol developed in the 1990s by Robert Gregg II and Delwyn McCarthy, commercialized through their company Millennium Dental Technologies, using their proprietary ND, YAG laser, the Periodontics. Single vendor, patent locked. When the evidence for a clinical claim comes predominantly from the entity that sells the product, the evidence demands a higher standard of scrutiny, not a lower one. That is not suspicion. That is how evidence-based medicine works. The protocol has 4 steps. A first ND, YAG pass to selectively ablate diseased pocket epithelium, closed flap conventional scaling and root planing. And here is a fact many patients do not realize: the laser does not remove calculus because ND, YAG is poorly absorbed by hydroxyapatite, so the scaling is still conventional hand instrumentation. A second lower fluence pass for hemostasis and fibrin clot stabilization, and gingival compression, no sutures. The selling point: flapless, minimally invasive, less recession, less postoperative pain. This comfort claim is less disputed and has case series support. Patients generally tolerate it well. That part is not the controversy. The core claim: true periodontal regeneration, new cementum, new periodontal ligament, new alveolar bone. The Marquis Histologic Study, Yukna, Carr, and Evans, 2007. 6 patients, 6 paired single-rooted teeth, moderate to advanced chronic periodontitis, teeth scheduled for extraction. At 3 months, removed end block for histology. All 6 LANAP specimens showed new cementum and new connective tissue attachment. 5 of 6 controls showed long junctional epithelium, no new attachment. But N equals 6. 6 patients. Far too small to generalize. Industry supported. And this is still effectively the only histologic human evidence for the regeneration claim, repeated across nearly 2 decades of marketing without an independently replicated larger study. A single 6-patient study, run by the patent holder, is still the marquee citation in 2024-era patient marketing. I want you to sit with that. Not to dismiss it, 6 patients showing new attachment is genuinely interesting, but to feel the gap between interesting and settled. The larger clinical literature, case series, retrospective cohorts, shows probing depth improvement consistent with what conventional therapy also achieves. Newer randomized trials show greater pocket depth reduction versus scaling alone, but a 2023 systematic review found only 4 randomized trials using 4 different laser methods, making meta-analysis impossible. You cannot pool 4 studies that used 4 different protocols and extract a single confident answer. The skeptic position, named and in full. The American Academy of Periodontology, in 2018, an AAP Best Evidence Consensus, screened 475 articles, found only 28 met inclusion criteria, and concluded the evidence was insufficient to support broad conclusions or clinical practice guidelines. The panel explicitly said this is not a verdict that laser is more or less beneficial. It is a statement of evidentiary insufficiency. The honest synthesis. Lasers can be safely used as a periodontal adjunct by trained clinicians. Bacterial reduction and improved comfort are plausible and have some support. Whether this is a clinically meaningful improvement over well-performed conventional therapy, and whether it is genuine reproducible regeneration at scale, both remain unproven at the rigor level the claim would normally require. The AAP 2018 framing, insufficient, not meant to insinuate more or less beneficial, is worth quoting, because I think it is the most honest single sentence in the entire periodontal laser literature. It does not say lasers do not work. It does not say lasers do work. It says, we do not yet have the evidence to know. Chapter 7, The Canal That Files Cannot Reach. Endodontics is, at its heart, a microbiological problem masquerading as a mechanical one. You shape the canal, you fill the canal, but the real battle is the bacteria, the ones hiding in places your files never touched, in places your irrigant never reached. Enterococcus faecalis and polymicrobial anaerobic biofilms hide in dentinal tubules, isthmuses, fins, lateral canals, anatomy files cannot reach. Bacteria penetrate tubules to depths of roughly 1,000 micrometers. Syringe-delivered sodium hypochlorite achieves effective penetration of only about 130. The gap is real, and it is the rationale for any disinfection adjunct, laser, or otherwise. In the Indian context, this gap is compounded by a specific clinical pattern. Many practitioners observe that a significant proportion of endodontic failures in India involve patients whose coronal seal failed years earlier, leaving the canal exposed to oral fluids for months. That dramatically increases the polymicrobial biofilm complexity before you even begin retreatment. The Photona protocol, called PIPS, photon-induced photoacoustic streaming, is the most technically elegant laser endodontic approach, and I want to walk you through the mechanism because it is genuinely beautiful. An YAG pulse at 20 millijoules, 50 microseconds duration, fires through a small-diameter tapered tip placed only in the pulp chamber, not advanced into the canal. The energy is absorbed almost completely by the water molecules in the irrigant. Near instantaneous vaporization. A cavitation bubble forms, expanding rapidly, then collapses, implosion, and that collapse generates a secondary shockwave. The shockwave propagates apically and laterally, creating transient acoustic streaming that drives irrigant into lateral canals, isthmuses, and dentinal tubules. The flow is far more vigorous than the gentle slosh of needle irrigation. This is active, turbulent fluid motion driven by repeated cavitation events. It is, in essence, a tiny, controlled, repeating explosion in the irrigant that physically drives fluid into anatomy no needle could reach. I find it genuinely thrilling. The idea that you can use light not to cut, not to burn, but to move fluid is a fundamentally different kind of laser interaction. SWEPS, the evolution, fires two ultrashort micropulses separated by an optimized delay, specifically chosen so the second pulse arrives while the first cavitation bubble is still present. Stronger streaming forces, higher shear stress on canal walls. The physics is real and well documented in lab models. But here is the honest caveat. Essentially, all the strongest quantified bacterial reduction numbers come from ex vivo and in vitro models. Extracted teeth inoculated with E. faecalis monoculture biofilms. The living tooth has pulpal tissue remnants, a complex polymicrobial biofilm with fungal components, host inflammatory exudate that changes fluid dynamics, and a closed intraosseous environment with back pressure from the periapex. None of those appear in the extracted tooth model. The leap from kills more bacteria in an extracted tooth to your root canal will heal better and last longer, is the gap that should be named explicitly. Clinical outcome data comparing laser-activated protocols to well-performed conventional irrigation is sparse and not yet conclusive. An umbrella review in 2024 framed it cleanly. Promising lab data, clinical superiority not yet established. And there is a 4-arm randomized trial I find particularly instructive, SWEPS, PIPS, sonic activation, and ultrasonic activation compared head-to-head for postoperative pain. Despite physics suggesting a clear hierarchy, patient-reported pain was statistically equivalent across all 4 groups. A humbling result. Physics elegance does not automatically translate to clinical superiority. There's also a cost reality for the Indian listener. A Photona YAG platform costs 25 to 40 lakh rupees. A routine root canal in many Indian cities costs a few thousand rupees. The vast majority of Indian endodontists still rely on conventional needle irrigation. A smaller segment has adopted ultrasonic activation, and only a tiny fraction have access to laser-activated irrigation. The clinical pearl I want you to take from this chapter. The PIPS tip must stay in the pulp chamber, not advanced into the canal. Clinicians trained in other laser techniques instinctively try to get closer to the apex. Doing so with PIPs defeats the mechanism. The shockwave needs chamber space to develop. No contact, no advancement. And optimize your chemistry first. The irrigant concentration and exchange protocol matter at least as much as whether you activate it. A well-prepared canal with strong conventional irrigation may outperform a poorly irrigated canal with the most sophisticated laser activation. The laser amplifies good irrigation. It does not rescue poor irrigation. Chapter 8: The surface you cannot afford to alter. If endodontics is a geometry problem, Implantitis is an engineering paradox. You must clean a surface you cannot afford to alter. That is the sentence I want you to hold through this entire chapter, because every clinical decision in laser implant debridement comes down to that tension. Implantitis is harder than periodontitis because the implant surface is not a natural root. Micro-roughened surfaces enhance osseointegration. That roughness is why the bone grabs hold so well. But that same roughness creates a biofilm retentive topography that is extraordinarily difficult to debride without altering. A clinician uses a titanium curette to debride an exposed implant surface, and under scanning electron microscopy, the curette leaves visible grooves on the titanium, permanent surface alterations that can increase future biofilm retention. The safe mechanical instrument also damages the surface. The very thing you are trying to clean, you are scratching. That is why clinicians turn to non-contact methods like erbium lasers. Erbium wavelengths are paired with titanium because titanium's melting point is well above correctly parametrized erbium pulse temperatures, and erbium's energy is preferentially absorbed by water and organic biofilm rather than the metal itself. The erbium pulse fires at the implant surface with water spray. The energy is absorbed into the water layer, causing microexplosions and cavitation at the biofilm implant interface. This mechanical disruption dislodges biofilm without needing to heat or ablate the underlying titanium. The water spray is not auxiliary, it is mechanism critical. It provides both the absorption target and active surface cooling. Running erbium dry on titanium is a serious clinical error. But no damage is parameter dependent, not a property of erbium per se. At safe fluence levels, the temperature rise is minimal. At higher energy, there is a measurable increase at the abutment implant junction. At still higher energy, the temperature rise approaches the concern zone for peri-implant bone. The safe window is narrow. It is not safe at any setting. Longer pulses, lower peak power, water cooling, careful tip distance, that is the safe window. And a surprising finding: the implant abutment connection type itself influences temperature rise. The implant system changes the thermal risk profile. You cannot transfer parameters blindly from one implant system to another. The authoritative current verdict. The European Federation of Periodontology published an S3-level clinical practice guideline in 2023 that endorses erbium laser use in non-surgical peri-implantitis management. A 2025 meta-analysis, 15 randomized trials, 540 patients, found YAG produced a statistically significant probing depth reduction of 0.65 millimeters versus comparators. Real, quantified, RCT supported. But 0.65 millimeters is a modest absolute effect, and probing depth is a surrogate measure. not disease resolution. And the line that I think is the single most important quotable sentence in the implant laser literature. Multiple independent reviews converge on the same finding: strong scientific evidence that adjunct laser application can provide better results only in the short term, 3 months, with no strong evidence of long-term benefit. State it plainly. Do not soften it. The benefit is real, it is measurable, and it is temporary. And the India-specific context. Diode lasers, starting as low as 15,000 rupees, are far more common than erbium lasers in Indian clinics, by a significant margin. Many Indian clinicians attempt erbium-level claims, peri-implantitis decontamination, with diode lasers. But erbium is the well-studied wavelength for titanium. Diode on titanium has less supporting evidence and higher thermal risk. You cannot make erbium claims on a diode budget. The wavelength determines what the physics allows, and on a titanium implant surface, the diode and the erbium are not interchangeable. Chapter 9, Light That Heals. I need to devote a chapter to photobiomodulation because it is the most evidence-contested area in this entire field, and it is where public confusion is highest. The word laser covers both a scalpel surgical lasers at watts and a biological signaling tool, PBM, at milliwatts. Conflating the two is the root of most public misunderstanding. A patient hears laser therapy and imagines a beam cutting tissue. What they may be getting is a light dose that does not heat, does not cut, does not vaporize, it signals. Photobiomodulation, formerly low-level laser therapy, is light at power too low to cut, vaporize, or coagulate. Photochemical, not photothermal. The mechanism: red and near-infrared photons hit cytochrome C oxidase, complex 4 in the mitochondria. Under stress, nitric oxide binds and blocks it. Light photodissociates the nitric oxide, oxygen rebinds, electron transport resumes, ATP increases. Downstream, calcium modulation, growth factor activation, fibroblast proliferation, reduced C-fiber nerve excitability. The upstream mechanism is well supported. The exact transcriptional cascades remain debated. I find it genuinely elegant that the same tool can be a surgical instrument at one power and a cellular signaling device at another. The key caveat that explains a huge share of contradictory trial results: the biphasic dose response. Low fluence stimulates, there is a peak effective dose. Then the effect plateaus and reverses into inhibition. More power equals better is wrong for PBM. Many negative studies simply use the wrong dose. Before you extrapolate one trial's result to a different device, ask what wavelength, what fluence, what protocol it actually used. A study showing no effect may be showing wrong dose. Not PBM does not work. The applications ranked by evidence quality. Oral mucositis in cancer therapy. The strongest evidence, the only application with formal guideline-level backing. The MASCC and ISOO mucositis guidelines recommend PBM for prevention in adult patients receiving high-dose chemotherapy for stem cell transplantation, head and neck radiotherapy, and concomitant chemoradiotherapy. Level of evidence 1 with a formal recommendation grade. This is not a maybe. This is a guideline. For cancer patients whose mouths are being destroyed by treatment, PBM prevention is one of the few interventions with formal backing. The caveat: prevention evidence is strong. Treatment of already established mucositis is thinner. Do not conflate the two. TMJ disorders and myofascial pain, moderate, genuinely promising. PBM works better for muscular myofascial TMD than intraarticular disc and joint TMD, a distinction marketing usually erases. The muscle responds, the joint less so. Dentin hypersensitivity, weak to moderate. Systematic reviews report 60 to 98% improvement, but that enormous range is itself the red flag. No dedicated Cochrane review exists. Best framed as an adjunct. Orthodontic pain and tooth movement, overhyped relative to actual grade. The most rigorous review found acute pain reduction graded very low and low quality. Tooth movement acceleration, only 3 qualifying studies, very low. Relapse prevention, 0 qualifying studies. A marketing claim with no direct trial support. Post-extraction pain and dry socket, Mixed, better supported for dry socket pain specifically. Paresthesia and inferior alveolar nerve repair, promising case series, no large randomized trials. Legitimate, low-risk adjunct worth trying, not a guaranteed fix. Recurrent aphthous ulcers and herpes labialis, moderate to good. A 2024 meta-analysis found reduced pain in 13 of 14 studies and shortened healing in 4. But PBM speeds healing and reduces pain. It does not alter the underlying etiology. New lesion recurrence is unaffected. The most important credibility point. Across nearly every application, the most common reviewer complaint is not no effect. It is parameters too heterogeneous to pool. Wavelength, power, fluence, continuous versus pulsed, session number, contact versus non-contact, spot size all vary study to study, often by orders of magnitude. Before you buy a PBM device or adopt a protocol, you must ask what the evidence actually tested, not what the device is marketed to do. The gap between the tested protocol and the marketed indication is where the disappointment lives. Chapter 10: The Myths. There are myths in laser dentistry, and I want to bust them with relish, because protecting the listener from misinformation is part of my job, and in a medical field, it matters more than usual. Lasers are always completely painless, no anesthesia ever. The reality: soft tissue work often genuinely skips the needle, but hard tissue work, deep caries, bone procedures routinely still need local anesthesia. Painless is wavelength and procedure dependent, not universal. The honest version: lasers can reduce anesthesia usage in certain procedures, not eliminate it. A patient who was promised painless and then felt pain has lost something more precious than comfort. They have lost trust in you. The laser replaces the dental drill entirely. The reality: hard tissue lasers are 3 times slower for bulk reduction, cannot cut metal or ceramic, cannot do full crown preps, and most laser practices still keep a drill. A hybrid workflow. The laser is an additional tool on the tray, not a replacement for the tray. One laser does every procedure. The reality: wavelength dictates tissue interaction. A diode cannot do a filling. An YAG cannot match a diode for certain coagulation. Many full laser practices own 2 or 3 systems. The physics does not bend for convenience. LANAP reliably regrows lost gum and bone. The reality: LANAP is a legitimate, less invasive alternative with documented pocket depth benefits. Saying it regrows bone as a guaranteed outcome overstates the evidence. The histologic evidence is a single 6-patient industry-associated study. The AAP says insufficient for broad conclusions. Both things are true at once. And now the single clearest case of marketing outrunning evidence: laser whitening. Multiple systematic reviews find no significant efficacy benefit from light or laser activation over high-concentration peroxide gel alone. Where some immediate shade improvement was seen, shade rebound occurred within the first week. The active bleaching agent is doing essentially all of the whitening work. The light is, at best, a minor accelerant, buying chairside speed, not better or longer-lasting results. In India, laser whitening is commonly marketed at 6,000 to 20,000 rupees as a premium service. The laser component of that pricing is not buying superior whitening per the evidence. It is buying speed and branding. Lasers are 100% safe. The reality: dental surgical lasers are class 4, the highest hazard class. Real risks include retinal and corneal eye injury, skin burns, fire in oxygen-enriched environments with documented patient fire case reports, and plume-carrying viable bacteria and viral DNA. Lasers are safe in trained hands with correct controls, not risk-free by nature of being light-based. And the overskeptic mirror image, because intellectual honesty runs in both directions. Lasers are just expensive marketing with no real benefit. Also an overstatement. Genuine, reproducible benefits exist: better hemostasis, reduced sutures, measurable antimicrobial adjunct effect, patient comfort gains, the bloodless field that changes workflow, the Erbium cold chisel that reduces injection rates, the mucositis prevention that has guideline-level backing. The honest framing: lasers are a real clinical tool with genuine, narrow advantages, not a universal upgrade, not a gimmick. Match the claim to the procedure and check the literature, not the brochure. And when you hear a claim that sounds too good, ask yourself, which chromophore, which wavelength? What does the evidence actually show? Chapter 11, Respect the Instrument. Before any laser touches tissue, the operator must internalize a hazard model that is wavelength-specific, Class 4 grade, and littered with quiet failure modes. This is not a chapter about fear. It is a chapter about respect. The eye injury is the central safety drama, and it is wavelength-specific. Visible and near-infrared wavelengths, diode and D, YAG, pass through the cornea and lens and focus on the retina. And here is the chilling part. The retina has no pain receptors. Damage is permanent and undetected until vision loss is noticed. By the time you notice, the damage is done. There is no warning shot. The beam is focused by the eye's own lens onto a point on the retina, concentrating the energy, and the tissue burns silently. Mid and far infrared, YAG, carbon dioxide, are absorbed at the cornea, which has high water content. More immediately painful and more regenerative, but still serious. The hazard profile flips completely between wavelength bands, and that is why eyewear must be wavelength matched. Diode goggles are constructed differently from Erbium goggles, which are different from carbon dioxide goggles. Wrong wavelength eyewear gives a false sense of safety while providing zero actual protection. The laser safety officer must verify the correct wavelength and optical density match before every use. Not occasionally, every use. The fire hazard. Class 4 lasers are recognized ignition sources. Supplemental oxygen via nasal cannula, common in sedation dentistry, can pool into localized pockets intraorally. Alcohol-based antiseptics are flammable, and patient fires during dental care are in the peer-reviewed record. This is not theoretical. The combustion triangle is real. Heat source from the laser, fuel from the antiseptic, oxidizer from the supplemental oxygen. The control: stop supplemental oxygen flow for about a minute before firing and use intraoral suction to clear oxidizer-enriched gas. A written fire and oxygen protocol, not left to memory. Memory fails under time pressure. Protocols do not. The plume hazard. Laser ablation plume carries viable bacteria, viral DNA, and infectious viral particles. The control: high volume evacuation close to the ablation site, and masks surgical grade minimum, respirator grade for higher risk procedures for all chairside personnel. A controls problem, not an unsolvable hazard, provided evacuation is actually used. In a busy practice, it is easy to let the HVE drift from the optimal position. The safety system degrades quietly, not dramatically. The required controls as a complete model, because partial safety is not safety. Wavelength-specific protective eyewear for operator, assistant, and patient every use. A designated laser safety officer, named, trained, not a rotating duty. Warning signage at the treatment room entrance. Controlled access, no casual entry while the laser fires. Non-reflective instruments, a stray reflection off a standard dental mirror can become its own secondary hazard source. High-volume evacuation for every plume-generating procedure, and a written fire and oxygen protocol. These are not suggestions. They are the minimum standard of care for a Class 4 device, and in a malpractice context, the question will be whether you met that standard, not whether you meant to. The certification that matters is the Academy of Laser Dentistry's standard proficiency, a psychometric exam plus a hands-on clinical simulation. This is the credential to look for, not a manufacturer's in-house demo certificate. A one-day course teaches you to turn the machine on. A certification program teaches you to use it safely on a human being. The difference is not semantic. It is the difference between a practitioner and a hazard. Chapter 12, The Honest Cost. Let me talk about money, because in this field, money is not a side conversation. It is a clinical decision. The laser you can afford shapes the procedures you can offer, and the procedures you can offer shape the patients you can treat. The equipment tiers are clear. Entry soft tissue diode, $4,000 to $10,000 new in the US. In India, basic units start as low as 14,000 rupees, and I must flag those honestly as likely very basic, low-power units where specifications and after-sales support need careful verification. up to around 3 lakh rupees for a 10-watt touchscreen system with dual wavelengths. The Diode is where most practices start. Lowest capital, widest applicability, shortest learning curve, fastest payback. All-tissue erbium and carbon dioxide systems, Waterlays, Lightwalker, Solia, run well into the $50,000 to $100,000 range new. In India, all-tissue systems can reach 25 lakh rupees plus, and they are import-dependent with customs and service overhead. The 5 to 10 times price jump from Diode to all-tissue is justified only by procedure volume, not novelty. Volume matters more than capability breadth for your first laser. And the hidden recurring costs that erode ROI if not modeled upfront. Disposable fiber tips at 1,000 to 1,600 rupees each in India, every procedure, every time. Safety infrastructure, wavelength-specific eyewear, the laser safety officer designation, warning signage, plume evacuation. Eyewear needs replacement. Staff turnover requires retraining. Maintenance contracts for imported systems, local service infrastructure is thinner than for diodes. All of these are real costs that appear in no marketing brochure. And vendor opacity, manufacturers rarely publish official list prices. The real list price is a conversation, not a catalog entry. The practical decision-making framework I want to leave you with. Start with a diode. Pick 2 or 3 procedures first, gingivectomy, frenectomy, aphthous ulcer treatment, and build clinical confidence and patient communication scripts before expanding. Model your ROI on 5 variables: the incremental fee per laser-assisted procedure, the procedure volume per month, the consumable cost per procedure, the financing cost, and the training time cost. If the numbers work, add an Erbium as a second-stage investment. If they do not, you have lost nothing by starting narrow. The worst decision is not buying the wrong laser. It is buying a laser you cannot amortize and then feeling pressured to overuse it or overclaim its benefits to justify the purchase. Calibrate your marketing to your evidence, or your malpractice exposure calibrates itself to your marketing. And the India-specific framing. Roughly 8% of Indian dental clinics use laser systems, compared to roughly 68% in US and Western surveys. That is a structural gap reflecting import cost, distribution friction, and training infrastructure differentials. Premium global platforms are entering at scale via large chains. Photona announced a partnership with Clove Dental to supply Lightwalker systems across 200-plus clinics. Independent and smaller clinics face a steeper cost and training barrier. Both are happening simultaneously. The honest question for an Indian practitioner is not should I buy a laser, but which laser, for which procedures, at what volume, with what training, and can I sustain the recurring costs? Answer those questions honestly, and the decision makes itself. Chapter 13, The Frontier. I want to close the technical story with the frontiers, because a field that is still being built is more interesting than one that is finished. And laser dentistry is, in the most honest sense, still being built. All-tissue single-unit lasers have crossed into mainstream. Solia announced its 2,000th unit installed across North America in January 2025. Photona announced a partnership with Clove Dental, one of India's largest chains, to supply Lightwalker systems across 200-plus clinics. Waterlays iPlus 3.0 launched with AI-assisted treatment presets and a real-time analytics dashboard. These are real products, shipped to real clinics, not concepts on a roadmap. The other frontier is integration into the digital workflow. Laser prep followed by intraoral scan and same-visit CAD/CAM design is no longer a demo booth scenario. It is a routine path in practices that have already digitized. The laser softens or removes tissue, the scanner captures the architecture, and the mill or printer produces the restoration in the same appointment. The value is workflow speed and patient convenience, not a magical improvement in the restoration itself. Blue diode lasers at 445 nanometers are a genuine technical refinement. 2 watts at 450 produces roughly equivalent soft tissue cutting to 3 watts at 980. Lower power for equivalent cut means less collateral thermal damage and better hemostasis. Blue diodes are entering the market in dual wavelength units that combine blue and near-infrared, giving the practitioner two chromophore profiles in one handpiece. Night lays for snoring and mild sleep apnea has a real mechanism, YAG in non-ablative mode inducing collagen tightening in the soft palate, and patient satisfaction data showing roughly 80% satisfaction. But the evidence is case series only. No large randomized controlled trials. Not standalone for moderate to severe apnea. An adjunct for mild cases, at best, while the evidence matures. And one more frontier worth naming. Antibacterial photodynamic therapy, where a photosensitizer dye is applied to a periodontal pocket or endodontic space, and then activated by a diode laser, producing reactive oxygen species that kill bacteria. Some comparative evidence suggests it may be equivalent to laser-activated irrigation for bacterial reduction, which, if confirmed, would challenge the premise that the expensive YAG is always necessary. That is a frontier that could be particularly relevant for the Indian market, where the cost gap between Diode and Erbium is largest. Chapter 14, Light in the Mouth. So here is the honest future of laser dentistry, after everything we have covered. The laser is a real clinical tool. It is not a revolution that replaces the drill and the scalpel. It is not a gimmick. It is a photon-level instrument whose capabilities and limitations are both determined by the same physics, chromophore absorption, wavelength selectivity, the Erbium microexplosion. The diode gives you the bloodless field. The Erbium gives you the cold chisel. The YAG gives you the periodontal pocket. The carbon dioxide gives you 50 years of soft tissue excellence plus, with the 9.3 micron tuning, the newest hard tissue capability. Each of them does what its wavelength allows and nothing more, and that nothing more is not a failure. It is the physics being honest with you. The physics is always honest. It is the marketing that sometimes is not. The evidence is strong where it is strong. Mucositis prevention with guideline-level backing, soft tissue hemostasis, anesthesia reduction in cavity prep, the bloodless field that changes your workflow. The evidence is contested where it is contested. LANAP regeneration, endodontic superiority, whitening, orthodontic acceleration. The evidence is thin where it is thin, long-term implant outcomes, PBM durability, night lays for sleep apnea. Knowing the difference between those three categories is what makes you not just a laser user, but a laser dentist. Someone who matches the wavelength to the tissue, the claim to the evidence, and the marketing to the truth. The gap between excitement and evidence is the throughline of this field. It was there when Goldman pointed a ruby laser at his brother's tooth in 1965. It was there when the Erbium breakthrough finally cut enamel in 1997. It is here now, in the regeneration claims, the whitening claims, the acceleration claims. The practitioners I trust most are the ones who can hold both at once. The genuine excitement of a technology that does things no burr or scalpel can do, and the honest discipline to say this is what we know, this is what we suspect, and this, gloriously, is what we still do not know. I promised you honesty at the beginning, and I hope I have kept that promise. I want you to feel something as we close. The next time you hear a popping sound in a dental operatory, that is not a drill. That is a tooth being blown apart by its own water, in millions of tiny controlled explosions, by a beam of light. The idea traveled from a physicist's desk to a dermatologist's brother's mouth, and then through 30 years of failure and stubbornness to the moment when it finally became safe enough to cut a tooth. And you are the one holding the instrument at the end of it. That is laser dentistry. Light in the mouth, physics in the chair, evidence in the balance. They are all, in the end, instruments of care. And the light, like the instrument, is only as good as the hand and the judgment that guide it. Thank you for traveling this journey with me. I hope it has left you, as it has left me, with a deep respect for what light can do in the mouth and an equally deep respect for what it cannot. Both of those, held together, are the practice of laser dentistry.